Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and we are in the middle of Women Health Month. And today I am so happy that we've got Dr. Greg Kashkarian here from Pima Heart and Pima Heart and Vascular, sorry about that, and Susan Smith from our Women Heart Support Group. Dr. Kashkarian is a cardiologist with Pima Heart. He attended Yale University School of Medicine and completed his fellowships in heart failure at Columbia Presbyterian Medical Center, as well as a fellowship in general and interventional cardiology at Georgetown. Dr. K enjoys helping patients learn about heart disease, how it starts, how it progresses, and what a person can do to gain control over the process. Susan is also with us, and she is a heart attack survivor and a Women Heart champion. So Susan facilitates our TMC Women Heart Support Group. Her passion is to help women become heart smart. So welcome to you both. Thanks for being here.
Thank you.
Thank you, Maya. I'm so happy to be here. I'm so excited to be here alongside Dr. Kashkarian during Women's Health Month to speak to this very important topic. As Maya said, I am a heart attack survivor, and I'm 3 years out from my heart event. So about 3 years ago, I was doing my thing, had a very busy day with a long to-do list, but something wasn't right. I was lightheaded, short of breath. I had a nagging pain in my collarbone, and I was so tired. The fatigue was unbearable. But I did what we women do best, and that is push through any discomfort. Because I had a lot to do. I was taking care of everybody else. I was taking care of everything. I didn't have time to take care of myself. So what I didn't know is that those few things are symptoms of heart attack in women. But by early afternoon on that day, I found myself at Tucson Medical Center in the emergency room in full denial. They told me I was having a heart attack, and I said, that can't be. I feel fine. I don't have any chest pain. I've got to go. I'm too busy. I mean, literally, that's what I said. But it took a few minutes, and they had me on a gurney, and I was in the cath lab, and I had my first stent that day, and the next day, I got another stent. So many women don't know that heart disease is the #1 killer of women. It takes the lives of 1 in 4, where breast cancer kills 1 in 8. 48 million women are living with or at risk of heart disease in the United States. Dr. Kashkarian, can you describe how symptoms of heart attack are different for women and why?
Sure. Nice to talk to you, Susan, and thank you for sharing your story. It is typical in so many ways of what women experience, from the denial that you could really be having a heart attack to the I'm too busy, I'm taking care of other people, they rely on me and not looking out for yourself. And then the symptoms you had aren't the kinds of things we read in textbooks where we're supposed to have crushing substernal chest pain, and that's the most typical symptom. It is interesting that women often don't have those typical symptoms. It can just be shortness of breath. It can just be profound fatigue. Sometimes it's just discomfort in the left arm or just an ache in the jaw. One of the things, and I actually looked at studies at why women have different symptoms. One of the things that comes out is that a lot of times what makes women have less typical symptoms is because women are relatively older when they have their heart attacks, and older people in general have less typical symptoms. So that is one of the reasons. The other thing is that women are probably more aware of their bodies and are more able to describe other kinds of things besides chest discomfort that men maybe aren't paying attention to, and they may only notice the chest pain and not notice the jaw ache or the arm discomfort. But these are your experience is quite in line with what people describe and what I've seen over the years.
Well, thank you so much for those facts and for your insight. I find it interesting that there is a difference of whether it be perceived or real and between men and women's symptoms. I think when I do talk to men who've had a heart attack, the one we share in common, I think, is shortness of breath. That was mine. But I think one of the scariest aspects of me as a woman having it was that women are inclined to delay getting care because, as you said, we're too busy taking care of other people. So what do you think about prompt evaluation for us? I mean, I know that I put it off and I was in denial. So what can we teach women to know to do better next time?
Yeah, I mean, it is so critical to get prompt care. If you're having a heart attack, that means that heart muscle is dying. And with time, more heart muscle dies, and there is less heart muscle, therefore, to be salvaged. So if an artery becomes occluded, there is a period of time in the next few hours where that heart muscle will all die, and it'll be too late to open up the vessel. So prompt care is very important. And one of the things that some of my patients will say after they've gone to the emergency room and found that there wasn't a problem was, oh, it was a waste of time, or I guess I didn't need to go. But you can't know that ahead of time. So if you're having symptoms that seem like they could be from your heart, the safest thing is to get them checked out immediately. If it is a heart attack, you've just saved your life or at least your future health. And if it isn't a heart attack, you've been careful and made sure that something bad isn't happening. That's not a failure to find out after going to the emergency room that it wasn't a heart attack.
One of my heart sisters says, I'd rather have a hospital bill and not have had a heart attack than the other way around.
Yes.
I mean,
that is true. Than an undertaker's bill.
That's true. That's true. So maybe we can look at a different approach. Like, what are some of the risk factors that women should be aware of? I know that I considered myself to be reasonably healthy on that day and during that time. What should I have known then?
So as a cardiologist, when I'm assessing somebody in the office or in the emergency room having symptoms, I'm thinking about the likelihood that this could be their heart and thinking about the kind of other conditions that a person might have that would raise the risk. And we call them cardiac risk factors. So high blood pressure is a risk factor. We now know that that high blood pressure probably starts in the 120s over high 70s, although we don't treat it until it's over 130 over 80. But as blood pressure goes above the ideal of say 120 over 70, risk gradually goes up. Smoking is a huge risk factor. Diabetes is a huge risk factor. And I would point out that those two things in particular are things that really put younger women at risk. I've rarely seen women, say in their 30s, having a heart attack, except women with diabetes or who are smokers. Having a family history is a risk factor. So family history is considered a first degree female relative, sister or mom who had heart problems by the age of 65, or a first degree male relative by the age of 55. So that's another thing that we look at. One of the things that we've also come to realize over the last several years is that cholesterol is a risk factor, but not in the way we learned when I was in training in the 1980s. High cholesterol is something that virtually all of us have. So if you have sort of lived your life being told, oh, your cholesterol looks okay, it's average, or it's even, quote, below average, that just means below average for an American, where the average total cholesterol might be 200. And the average LDL is 130, but actually a biologically normal LDL cholesterol is 50. That's what we're born with, and it tends to go up because of the Western diet we eat. So if your LDL cholesterol is even 90 or 100, which for most people they think of that as good, that is still high enough to form plaque. So don't in your own mind think, oh, I couldn't possibly be having a heart problem because my cholesterol is so good. So these are some of the things I think are take-home messages for women and other people too.
Okay. You just said something that made me think of something that I'd like for you to emphasize.
Sure.
I believe that family history is one of the few risk factors that we can't control with diet or lifestyle.
Mm-hmm.
You can't pick, your generations back. So I like to tell people to go back at least 2 generations if you can, your parents, your grandparents. But you said, and I'm thinking about women here, but you said for women to specifically think about the women in their family, their mother, their grandmother, their sister, and then secondarily the men in the family. Is that what you said?
Well, I listed them kind of separately because the age cutoff for being premature heart disease is different in men and women. But genetically, women are as related to their fathers as they are to their mothers. So I wouldn't make the male relatives secondary.
Right.
So if a woman says, "Oh, all the women in my family have been healthy," it's just the men, the men in my family that have had problems. Unfortunately, that's not protective.
Right.
There's just the same genetic connection.
And you mentioned young women, unless they're smokers or diabetic. And of course, family history plays a role there too. But what about young women who are pregnant? I have met and know of cases where pregnancy puts a lot of stress on our heart. And I wouldn't say pregnancy is a risk factor, but what are your thoughts about pregnancy?
Sure. So, when I said about young women not being as prone to having heart attacks, I'm sort of thinking in terms of the standard mechanism of a heart attack, which is plaque building up in the artery, becoming unstable, a plaque breaking, closing off the artery. But you are right. Young women can have emergencies related to their heart. Pregnant women are at greater risk of having something called coronary dissection, which has to do with just the different biological state a person is in when they're pregnant, and that can cause a heart attack. Women who are pregnant are at risk of something called a peripartum cardiomyopathy, where the heart function gets diminished without there being a heart attack per se, but the symptoms can sometimes be quite significant, where a person can't breathe. So definitely younger women are at risk of certain things happening to their heart. Atypical causes of heart attacks as well as cardiomyopathy. So no, I don't want young women to think, nope, I can't have any heart issues.
No, I know that. There've been quite a few that I've known that have had their heart incident as young women during pregnancy. So I think these days, perhaps gynecologists can know or to send them on to a cardiologist if necessary. So as a grandma, I think that as a grandmother, I want to be sure that I just fill my young daughters in about that.
Sure.
I'm going to go on down this path about women's, those things that happen to some of us women. Some women I know had stress-induced cardiomyopathy. That's also referred to as broken heart syndrome or Takotsubo.
Yes.
I'd never heard of that in my life until 3 years ago. Can you tell us what that is and what triggers it, how it's treated, and why is it mostly women that get it?
So Takotsubo cardiomyopathy or broken heart syndrome is sort of an acute damage to the heart, often reversible, but acute damage to the heart that is often brought on by stress. It can be emotional stress, it can be physical stress. There is a typical look to the heart when people develop this, and that's where the word Takotsubo comes in. So that's Japanese for octopus net, and the ways they catch octopuses in Japan are through these containers that are sort of narrow, and then they flare out at the bottom, and that's what the heart looks like because it bows out at the bottom of the heart. The apex bows out, And so it has this typical pattern. And the pattern of where the heart muscle isn't contracting well is not in the distribution of, say, a single coronary artery. So we see and we think, gee, where could a blockage have been that caused this to happen? And lo and behold, when we do angiograms on these people, they often have no or minimal blockage. The mechanism of what causes it, despite this having been described probably 15, 20 years ago, is still not known for sure. Some of it is felt to be related to an abnormal outpouring of adrenaline from the brain due to these stressful things happening. Some people think it's related to microvascular dysfunction, but the treatment is kind of supportive. Often the hearts will recover, but while people are sick, they can be very sick. And so we give medicines that might support the blood pressure if necessary. We use medicines that we would use in other situations where people have weak hearts. Categories of medicines called beta blockers, ACE inhibitors, ARBs. I usually keep people on beta blockers long term because I'm a big proponent of the adrenaline hypothesis. And so I think that protecting the heart against the effects of adrenaline, which is what beta blockers do, can help prevent it. It is absolutely true that women are at higher risk than this. And I also looked into how that has been described in the literature. And nobody's that I've seen has come up with a good explanation for it. But women are almost 10 times more likely than men to have it. So it's clearly preponderant in women.
Okay, thank you. There were women in the audience or women that contributed to some of these questions that have had that. So I wanted to short Kim up.
Sure.
Mentioning adrenaline and beta blockers, is that why when we're on a beta blocker and we go and try and run on the treadmill or run, we can't get our heart rate up, and the beta blocker medicates us to keep things low and calm, and I mean, so that's the purpose of a beta blocker, is that correct?
Yes, yeah. It in a sense is putting a brake on how hard the heart has to work. And I'm glad you brought that up because this comes up a lot when people are exercising. Most of us are taught to shoot for particular heart rates with exercise. And without getting too much into exercise mechanics, a very simple concept is when we exercise, it is our body we are exercising, not our heart that we are exercising. Our heart is exercising all the time. We use heart rate mainly because your heart rate and the level it gets to is an indirect measure of how hard your body is working, and it's a fairly easily measured thing. But it actually isn't the true endpoint. The true endpoint is making your body work hard. And so people who are on beta blockers will find that their heart rate doesn't get up as high for the same level of exercise. And despite that, they are still getting the benefit. So I actually often use a more subjective means of telling people that they've hit a moderate level of exercise. I tell them they should be breathing heavily, but not gasping for air. They can have short conversations, but they wouldn't be able to have a long, fluid conversation. Another thing that people say is you can talk, but you can't sing. But they should be a little out of breath. If they're feeling like it's a casual stroll and they're having a fluent conversation, they're not pushing themselves enough to be exercised. And if you use that kind of a guideline, then you don't have to worry so much about what your heart rate is.
Good. Thank you for clarifying that, because I've talked to many people that have that experience, and they have determined that it is their medication, mainly the beta blocker. Okay, good. I'm glad to know that. Here's a question that came up. What accounts for the difference in heart damage following a heart attack? Some people recover and some live with limited functionality. For example, does ejection fraction ever go back to normal? There's a lot of talk about what an EF is. Could you tell us?
Sure. So ejection fraction is the percentage of blood the heart pumps out with each beat. So when the heart contracts, it doesn't contract with the walls coming all the way together where there's no blood left over in the heart. So a normal amount of ejected blood is about 55-60% or more. So only a little bit over half of the volume of the blood is ejected out. When the heart muscle has been damaged, it doesn't contract as vigorously, and so the ejection fraction goes down. The reason why some people's heart attacks are bigger and some people's smaller, part of that relates to our earlier conversation. If you get to the hospital more quickly and the artery is opened up more quickly, you will have less damage, and that will be a smaller heart attack. Some of it, unfortunately, is just luck. For instance, a heart attack can occur when a heart vessel becomes 100% blocked, but you can also have damage if it becomes 95% blocked, where there's a little trickle of flow, but not enough to have normal blood flow. And so you can have more slow damage to the heart. And so people with a 95% blockage can go to the hospital, have elevation of their heart enzymes, and the enzymes that we most often measure are called troponins. And it'll be a small heart attack, but lo and behold, on an angiogram, it'll be a very major vessel. But luckily for the person, that vessel didn't become 100% blocked and start causing much more rapid damage. And that also leads me to say that don't think of a small heart attack as something not to be worried about. Because a small heart attack, sure, it could be just a small vessel that became blocked, but it could be a large vessel that almost became completely blocked. And so take small heart attacks seriously.
So I want to thank you for mentioning enzymes. And tell us the name of that one enzyme again. The
troponin.
Because some people might be taking notes. It seems like that when you get to the emergency room, they do the EKG and they do a lot of tests, but they're checking your enzymes, because isn't the enzyme test, whatever it might be called, really the acid test to show if you've had a heart attack or if you are having one? How does it know? How do the enzymes tell you?
Right. So these new assays, and I'm going to spell troponin for people taking notes. It's Troponin. Okay. So a troponin assay currently can measure damage almost within 2 hours of starting to have damage to the heart. It will stay elevated for a few days. So the typical pattern is the troponins gradually go up, they peak, and then they come back down. They'll come down more quickly if you come in and have your artery opened up. So it doesn't detect an old heart attack, something that happened weeks ago, but it detects somebody in the process of having a heart attack or a very recent heart attack.
Okay. That clears something up for me and many of us, I'm sure. Thank you.
And I should add that not having a heart attack does not mean you haven't had a dangerous situation. So imagine you come into the hospital and you've been having chest pain that just started a few days ago. And every time you walk across the room, you have chest pain. You might have a 90% blockage that's causing you to have angina, which is the symptom of insufficient blood flow to the heart, but no heart damage has occurred. So the fact that the troponin is normal doesn't necessarily mean that there isn't a problem, only that you aren't having active heart damage.
Okay. Now you've said another word that I hear pronounced differently all across the board. Angina is how I've always said it. And then they say angina in my doctor's office. Is there a correct way?
I'm not going to say there's a correct way. What I will say is doctors tend to say angina, and non-doctors tend to say angina. And when I'm talking to non-doctors, I tend to say angina because I know that's the term that people are most familiar with.
Right. And I think in my whole memory of my life, I can remember people saying that word, and basically what it meant to them and meant to me is the pain or the discomfort that you're having. And like I said, many of us women say we're not having chest pain, we have this ache or this discomfort, but that's all angina, right?
Yes.
Okay.
And really, heart attack pain is angina. It's angina that doesn't stop and keeps going because you're having ongoing damage. It's usually more intense than the more limited episodes that people with chronic angina have. But it's qualitatively the same kind of thing. And actually that also brings up a point that we could have brought up earlier, which is people having a heart attack don't always have horrendous symptoms. Your symptoms were dramatic enough, even though they weren't typical, to at least get you to get them checked out. But a lot of people sit at home having their heart attack because it's just a vague discomfort in the chest. And they don't really feel that bad. They just feel like, oh, maybe I ate something bad. Maybe this is just indigestion. So the severity of the discomfort is not always proportional to the danger of what you're experiencing. So if you're having symptoms, say, above your diaphragm that you can't easily explain by something else you've experienced before, it is best to get them checked out.
Absolutely. I think that is a great bit of advice. Okay. Some women use over-the-counter supplements to support the management of their heart health.
Mhm.
Do you recommend any of these products, such as collagen, CBD? If not, why?
So I have to admit, I'm not a big proponent of over-the-counter medicine. Um, uh, Nothing inherently wrong where you have to have a patent on something to make it, to make it work. But because natural substances are able to be marketed without studies, they don't get tested as rigorously as the pharmaceuticals that we use. So most things you described, most things out there have never been tested vigorously in what we call randomized controlled trials. Now, that being said, if I sort of think of something where when I've kind of looked at the data, I think, oh, there is reasonable hope that this could be beneficial and I don't see anything wrong with it. One of the things I do talk to people about is using turmeric. So I actually take turmeric myself. It has antioxidant properties, and so that's one of the things I use. But I can't say that has been proven to be effective either. Just I think the data is a little better for it than some of the other things.
Good. Thank you for clarifying that. Okay, now on to the technical stuff. There are so many types of heart doctors out there: structural heart, electrophysiologists. How does a person know which type of doctor they need?
Mm-hmm. Yeah, it can be very, very confusing, and it was confusing for me when I was in training, trying to figure out which subspecialist to call. I think in general, it is best to start with a general cardiologist, because a general cardiologist, while they won't be able to necessarily do all the things that the electrophysiologist and the interventional and structural heart cardiologists do, they are familiar with all of those things, and they will often have ties to people in those particular specialties, and will certainly know which direction to refer a person. So earlier, Maya mentioned that I did interventional training when I was at Georgetown, but I actually don't do interventional cardiology anymore. I'm a general cardiologist, but at Pima Heart and Vascular, I have structural heart partners, interventional partners, electrophysiologist partners. So I know exactly who to refer somebody to when that is appropriate. And most general cardiologists can manage conditions short of needing a procedure to be done. So a lot of times people don't actually even need to get to the structural heart person. For instance, they might have aortic stenosis, and they may have read that, oh, these valves can be replaced through catheters that structural heart cardiologists do. And that is true, and we do lots of those through Pima Heart at TMC. But most people with aortic stenosis don't even need to have that done. It gets done when it becomes severe, and that's something a general cardiologist will track with a patient over time.
Okay, and just clarify for me and for those listening.
Mm-hmm.
I've heard it said that the two types of issues in our heart can be either plumbing or electrical. And I think we talked about that the other day. So plumbing is like a clogged pipe or a clogged drain. So when I had a clogged artery, they opened it up and put in a stent. What would be the electrical problem I might have?
Okay. The heart is a muscle and it contracts. And actually, I would add a third category, mechanical. So the contraction of the heart is the mechanical problem, and people can have damage to their heart or weak hearts for other reasons, like we've talked about. And there are particular medicines and possibly procedures to help with that. The plumbing, as you said, is the blood supply to the heart. So the heart doesn't pump if it doesn't get blood. And if the pipes are clogged up, they can be unclogged with stents, balloons, other procedures, bypass surgery. The heart contracts through a sort of electrical system, and there are specialized pathways that the electricity goes from the top chambers of the heart to the bottom chambers of the heart. And those pathways can also have problems. They can either have problems in that they have slow conduction and an advanced stage. That's one of the reasons people need pacemakers. The electrical pathways can also have problems where they become overactive and a person can develop a fast abnormal heart rhythm. And electrical specialists can often do things for those people, ablations, defibrillators. So those are the kinds of electrical problems that people might be faced with.
Thank you for clarifying that. These are, I guess perhaps because I'm a heart patient, I find all of this stuff fascinating, and I really like for the women in the audience to hear it and learn it. Next question. Do you have any patients or data on women who have reversed their heart failure and reduced or stopped their heart medication?
So definitely yes to the first question. A lot of causes of heart dysfunction leading to heart failure will reverse either with procedures that open up blocked vessels or medications that have helped strengthen the heart. Sometimes we are able to wean people off of some of these medications, but for a lot of people who've had severe heart damage that improved or normalized with medication, it really does become lifelong therapy. And the reason is that while some people, when they come off the medication, their heart function stays fine, lots of people, when they stop the medicine, the cardiomyopathy, which is the weak heart, returns. And I've even seen people that when they resume their medicine, they don't go back to normal again. So it's just too risky to let people stop medicines when they may develop a recurrence of the problem. Really have to take it case by case basis. Also what the cause of the cardiomyopathy was. But you know, much of the time people remain on medication.
Okay. As you can tell, some of these questions have come from our heart sisters, and some people want to get off their meds. Some people, you know, I can understand that.
Yeah, nobody likes taking medicines.
No, not especially when you got a whole pill box full every day. Okay, one question at the top of everyone's mind is related to the COVID-19 vaccine. Can you speak to women with heart disease or heart concerns and the vaccine?
Sure. I 100% recommend people getting vaccinated. There is no heart condition that should keep you from getting vaccinated, but the coronavirus infection puts everybody at risk of heart problems, and probably higher in people who already have heart problems. I had a scary situation several months ago with one of my patients. She'd had a couple heart attacks in the past, and she came in 2 weeks after being diagnosed with coronavirus, having a heart attack. She had clot throughout her one of her arteries, her right coronary artery. She had stents put in. She went home the next day. That night she came back and now had clots in her lungs from clots that had developed in her legs. They had traveled up to her lungs. They had actually, she had clots in her brain, so she had a stroke. So she had, you know, a terrible complication of the coronavirus infection, which is overwhelming clotting. We call it hypercoagulability, the tendency to form clots. And coronavirus does that to people. And certainly if you're somebody with a heart attack, you're at greater risk. You know, some people have side effects from the vaccine, but I really think it is nothing compared to some of the horrendous things I've seen with the coronavirus infection. So I encourage everybody to get vaccinated.
Okay, good. Thank you very much for that. Are there any other recommendations you have in terms of general wellness and heart disease management?
Sure. When you talked about your stirring story with your heart attack, and you had stents put in. And one of the things I emphasize to people is those are life-saving procedures, and I've done my fair share of them over the years. But what happens after that will impact a person's life even more than the stents that were put in. Because at that point, you have to be dealing with the plan of how do you prevent this from happening again. And I always tell patients that this is a partnership between the two of us. There are things I can do. There are medicines I can prescribe. I can try to control your blood pressure. I can control and lower your cholesterol level, and prescribe other medicines, blood thinners that will help you. But then there are things the patient needs to do. They need to eat a healthy diet, a diet that's low in saturated fats, that's low in simple carbohydrates, low in salt. A Mediterranean diet is a good heart healthy diet. And the other thing patients can do is be active. People are not active enough, not enough people exercise. I recommend 150 minutes of moderate level exercise a week, broken up into 4 or 5 days. So people should be exercising a majority of days of the week. So those are the things that patients can do to make themselves healthier, on top of the things that I can do and recommend to them.
Good, thank you. I know one of the first things that I did after my heart attack was go on a low sodium diet.
Mm-hmm.
And we don't realize as Americans what saltaholics we are.
Yeah.
We just really love that salt, potato chips, pretzels, everything. And I tell people that it took me about 2 weeks for my taste buds to adjust. And now if I taste something that's too salty, I can't eat it.
Yeah.
So it really doesn't take long. It's easily done. And the important thing is to read the labels, check the sodium content. And then secondly, I got on an exercise regime that was more about my heart. I mean, yeah, that is so true.
Good for you, and good to bring up.
Right. I have one other thing, but can we check in, and do you have questions from the audience? Because otherwise I've got a couple other things.
I do have some questions that have come in that I wanted to ask. Let's go back when we were talking about the family history for heart disease. One of the questions that came in is, what is the percentage of that's related to family history that would account for somebody's heart disease, as opposed to maybe the percentage that's based on stress?
Okay. I've never been asked the question in that way, and I can quickly say that it varies from person to person. So for instance, the more risk factors you have, like high blood pressure and higher cholesterol, smoking, diabetes, probably the less family history will be as a percentage of your risk, because you've got a lot of other competing risks. But let's say you don't have a lot of those other risk factors, then your family history plays a pretty big role. Stress is hard to quantify. It's easier to say, oh, you were in a stressful situation that precipitated something from happening, precipitated something to happen. It's hard to say how much does lifelong stress, how much of a role does that play in the gradual plugging up of arteries? And that's not something that's been easily to quantify in studies. But stress definitely plays a role. I wouldn't quantitate it. I also try not to emphasize that when I talk to people. People will say, "Is stress bad for me?" And the short answer is, of course. And if I confirm that for you, will you stop being stressed? So lots of times when you tell people stress is bad for you, it makes them more stressed. So I don't try to emphasize that so much. But certainly, if there are ways you can remove yourself from stressful situations, it's going to make you healthier mentally as well as physically.
Okay, great. And this is probably a question for both of you. What should a family member know to support women who might be during their recovery? And I know, Susan, you've been through this, and so what do you feel would be helpful for a family member to know?
I can answer that immediately, and then I'll let Dr. K go in too. I think your family members can be sure that you get enough rest. I personally still have to nap every day. If I don't get enough rest, then my energy is shot. And people can say, check in, have you rested today? Have you exercised today? And the other cautionary warning I get from my family is that you're trying to do too much. I backslide on this, taking care of everything and everybody. I go back to that because it's something that we women do very well. And someone will ask me to do something or help out, and before I can help myself, I'm doing too much. So my husband will say, "You're doing too much. You got to cut back." So those are the things that come to top of my mind.
Great.
Yeah, I mean, I would echo what you said. In my experience, I do find that the children of a woman who's had heart problems tend to be fairly cognizant of the issues and very very concerned. In this day and age, husbands are better than they used to be. Like when I compare the husbands of my patients 30 years ago to now, there are more men that will take over some of the duties that they had relied on their wives to do. But still, there are those that don't. And so I guess that would be the thing I would stress is husbands realize now you need to partly be the caretaker and shoulder some of the responsibilities of the things that your wife has been doing. So that would be the message I would give.
I think all the husbands should start cooking right after the heart attack.
Uh-huh.
And then I have one more question that came in, and it was about, can somebody who's had an aortic valve replaced via open heart have a TAVR in the future?
Short answer is yes. It depends on what type of valve was put in. So if it was a mechanical valve, unfortunately, no. To do what's called a valve-in-valve TAVR, you have to be able to put the new valve through the old valve and expand it with a balloon and sort of push the old valve out of the way. And you can do that with a biological valve. You cannot do that with a mechanical valve.
Okay.
Now there can be person-to-person differences where a particular person might not be a candidate for that, but at least people with biological valves are open to being evaluated for that possibility.
Great. And can you let us know, I was going to put up here about if somebody needed to see a cardiologist, where they would contact. And I've got the Pima Heart and Vascular phone number running across the screen. It's 520-838-3540 for anyone who might be interested and needs to talk to a cardiologist.
Sure.
So,
yep.
Susan, that was all the questions I had. Well, actually, I think, so all the questions I have. So if you have any other ones, we could probably take one more.
I do. And then at the end, would you put in a plug for the Women Heart Support Group that we hold at TMC? Okay. This one is important for us to answer. One of my heart sisters had a triple bypass 1.5 years ago. She said, I will either get a mitral clip or a tendon valve. Can you tell her about that?
So I have not heard of the expression tendon valve. Now, does she mean a bovine valve or porcine valve?
Sounds like a misspelling there. That might be it.
Yeah, and I should have asked you that because I did see that word out there. So a biological valve is usually from a pig or a cow, so bovine or more often porcine, and that means a valve replacement. A mitral clip is a sort of clip that keeps the two leaflets together and closes off the leaky valve, or at least it doesn't close it off completely, but it decreases the amount of leakiness. And whether a person is a candidate for a mitral clip relates partly to the anatomy of the valve, which can be assessed with a special echocardiogram called a transesophageal echocardiogram. It also relates to the risk of the surgery. So people who have who are at high risk of having open heart surgery are people that are more likely to be approved to have a mitral clip, because most structural heart teams have surgeons and structural cardiologists on the team that are assessing the relative risks of the two different procedures. Now, having had bypass surgery, this person is at higher risk because having a reoperation does put her at higher risk.
Yeah. Okay, good. Thank you. So speaking of that, before I finish up, I am amazed at what can be done now through our that can be put inside our bodies without open heart surgery. I know of stents for sure, but I've learned recently pacemakers, defibrillators, all kinds of things. Can you just tell us about those and what that process would involve?
Sure. And this kind of gets back to the other question about how do you choose which cardiologist you go to see. So, if I think of my interventional partners, you mentioned stents. There are atherectomy procedures using laser, rotational atherectomy, the Roto-Rooter device. So they have these tools in the cath lab. To my electrical partners, besides the pacemakers, they put in defibrillators. They have fancy pacemakers called biventricular pacemakers that can help restore heart function. There is another device that just got approved recently that is another electrical device that's implanted that helps the heart function better through a totally different mechanism of action. Some of my partners put in what are called Watchman devices. So those are devices that are put in to a particular part of the heart called the left atrial appendage. They plug up this little sac where clot tends to form in people with atrial fibrillation and allow people who can't take anticoagulants to have a lower stroke risk. To our structural heart colleagues, I send my patients who have valve problems. So aortic stenosis, mitral regurgitation, where clips can be used, TAVR can be done. Soon we'll be in a trial where we're looking at leaky tricuspid valves where we can put a tricuspid clip on. And as I mentioned, the Watchman device, which is something my structural partners do. So, there are so many different ways that people can be treated short of being opened up nowadays. And as I said, that's one of the reasons it's just good to get in to see the cardiologist and see a cardiologist who has access to these other types of specialties.
Absolutely. And I have to say, to be a heart patient in this era now, to have all this advanced technology and to be in Tucson, Arizona, the hub of all things medical, especially heart, I think we're very fortunate. So I want to thank you for being on with me today, Dr. K. He gave me permission to call him Dr. K because
That's fine. It's been a pleasure talking to you, Susan, and learning about your story. And I congratulate you on putting your own scary experience to good use for other women.
Thank you. Thank you very much.
I want to thank you both for being here as well. I did want to share about our Women Heart Support Group. Susan is the facilitator. We meet virtually on the fourth Wednesday of each month. And so you do need to register in advance so that you'll receive the Zoom link. If you give us a call, we'd be happy to send over that information to you. Or if you just have questions in general, we'll be happy to share. So. Also, thank you, Dr. Kashkarian. Again, I've got the number running for Pima Heart and Vascular as well, 838-3540. And I'm so glad to have you both here today to share. It was really wonderful to be able to really let women know what is important with heart disease. So thank you both for being here.
Sure. Thank you, Maya, for inviting us.
We do have a full schedule next week, so be sure to join us. We have our Whip It Up Cooking Club with C. Charo Concepts. We'll be focusing on avocados on Tuesday at 3 o'clock. We're doing varicose veins, preventions and solutions on Wednesday. And Thursday, we've got women in exercise. So it is a full week celebrating women. So thank you all for being here.
Thank you. Bye.
Thank you.